Hello, everyone, and thank you all for joining us today. On behalf of the Radiology Society of Rio de Janeiro and OCAD, I want to welcome and thank you all. My name is Aline Serfari, and I'm here with Dr. Hilary Humans, who coordinates and moderates this series with me. Our guest speakers today are Dr. Lucas da Gama Lobo, Dr. Diego Lemos, Dr. Francisco Abaeté, and Dr. Marcos Loreto Sampaio. The speakers will present their cases, and at the end, we will have a Q&A session. If you have questions at any time during their presentations, please put them in the chat box, and at the end, the speakers will respond to them. The presentations today will be recorded and available on demand on the OCAD website, which is ocadmsk.com, and also on the YouTube channel of the Radiology Society of Rio de Janeiro. If you want to join the OCAD community and see challenging cases almost every day, please consider registering on the OCAD website. A quick reminder, attendees have not been given the permission to screen record any of these presentations, as they may contain material under copyright. Unauthorized recording, use, distribution, and sale of this material without permission from the speaker is illegal. We thank you for your understanding. And with that, I will kick off the session. We have the pleasure of having here today Dr. Francisco Abaeté. He's an associate professor of musculoskeletal radiology at Christus University Center in Fortaleza, Ceará, Northwest Brazil. He completed residency, his musculoskeletal fellowship, as well as doctoral degree at Ribeirão Preto Medical School, University of São Paulo. He is the section head of MSK Image and director of the MSK Fellowship Program at Antônio Prudente Hospital in Fortaleza. He's also very involved in MSK radiology education, having presented at radiologic national and international conferences. He's interested in all areas of MSK imaging and intervention with emphasis on sports medicine. He's also a member of the International Skeletal Society, and he's a very good friend of mine and also a great collaborator in several educational projects here in Brazil. Please, Abaeté, share your screen.
Okay, good afternoon. I'm very pleased to be here, and I'd like to thank Dr. Aline and Dr. Hiller for inviting me. It's a pleasure, and a special pleasure to be talking about sports imaging. It's the main focus of my work here on a daily basis, so I like very much this topic. And thank you very much for the kind presentation. Here are my social media. If anyone wants to keep in touch. And how I said, I work almost every day with sport medicine exams. I'm part of the medical department of soccer team, a professional soccer team here, also football team and basketball team. And so we are involved in this multi-modality evaluation of these patients and also procedure in sports medicine. And so I will talk a little bit about this next slides. There we have a ultrasound department inside the medical department of the team. And when we need more exams like MRI or more complex procedures, we send the player to an outpatient facility that you can perform and follow up the. So to our today case, it's very interesting because it was from 2 days ago. It's a 25-year-old male, professional soccer player that developed severe pain and swelling in the proximal region of the leg after direct trauma. It was a tangential trauma last Wednesday during the game. So it's less than 48 hours now from the trauma. And yesterday he performed an MRI. And when I was preparing the presentation, I saw this case and I decided to change the case because I thought it was interesting to discuss the topic of this case, not because it's a rare case, but because it's an uncommon location of not rare situation. And I thought it would be interesting to discuss and review this topic. So this is the MRI of this player. It was performed, how I said, less than 24 hours after the trauma. So it's in an acute phase. It's about 12 hours after the trauma. And here it's a axial plane and a fluid sensitive sequence with fat suppression of the leg. And here we have a finding that it's very easy to detect. As you can see here, dissociation between the superficial fascia and the deep fascia here on the muscle compartment and the superficial muscle compartment here. So you can see this degloving injury in the anteromedial aspect of the leg. And here you see the subcutaneous dissociated from this deep fascia. And one of our interesting findings here is this fat tissue and small nodules inside this fluid collection, inside this effusion here. It's a very specific finding of the situation. We also can detect here associated muscle contusion in the medial aspect of the solear muscle, but the other muscle planes here are preserved. In this coronal image, also a fluid sensitive sequence with fat suppression, we can see the extension from top to bottom of this lesion. It's almost 16 to 17 centimeters long. And here I draw this small fat nodules here and this fat tissue inside this fluid collection, inside this effusion here. So with this image, I think you already know the diagnosis. How I said, it was not a uncommon diagnosis, but it's in an uncommon place, uncommon location, how we will see in the next slides. So it's a Morel-Lavallée lesion. It was classically described in the thigh. It was first described by a French physician in 1863, and it's a lesion that develops in soft tissue, resulting in an hemolymphatic collection between the fascial planes, the superficial and the deep fascia. But it can also be found in different locations, not only in this classic one. It was also called closed internal degloving injury, or post-traumatic soft tissue cyst, or Morel-Lavallée effusion, or chronic expanding hematoma. This is the classic location of this finding. So you have this deep fascia here, that's the fascia lata, and you have also a superficial fascia here. And when you have this dissociation, you have the degloving here, we can find the Morel-Lavallée lesion. Here we'll review the mechanism of this injury and the specific anatomy of this region, so we can understand how it occurs. These illustrations are cross-sections of the tissues layers from the skin to the bone, and demonstrates a shearing force that can cause a relatively mobile subcutaneous moves relatively to this deeper tissues that are fixed, and then you have shearing forces in these vessels that may be arteries or veins or also lymphatic vessels, and these shearing forces can cause lesions of these vessels, and then they can accumulate here this fluid collection that may be hematic or hemolymphatic, and depending on the proportion of different vessels that are involved in this lesion. They are frequently identified in hours after the trauma, how in our case, but it may be, depending on the mechanism of the trauma and the location, it may be diagnosed just after days or even months. It can be an isolated lesion, but often we can find fractures associated. And here in this image, we can see the most common places or potential sites of Morel-Lavallée lesions. And as you can see, the most common places are in the thigh and also surrounding the knee. But here in the leg, it's not common. It's between uncommon or a rare location of this lesion, as also in the dorsal region, the shoulder, or in the head. Melado and Bencardino described a classification, an MRI classification for this kind of lesion. As we can see here in this picture, the type 1 is a serohematic effusion, a seroma, very homogeneous here. The type 2, it's a subacute hematoma. Type 3, it's a chronic organizing hematoma. Type 4, it's a periphacial dissection with laceration, a fat laceration. Type 5, it's a periphacial nodule, pseudonodule lesion. And type 5, it's an infected lesion, okay? It's a chronic and infected lesion. I brought another case from the literature just to illustrate here, another case in the leg. Here with is a 57 years old man with lateral cuff swelling post-trauma. It's a type 2 Morel-Lavallée, as you can see here, subacute hematoma. There's another place, it's also very common in surrounding the knee. Here in the medial aspect of the knee, we can see the ultrasound in correlation with the MRI, and it's also, this is a type 1. It's a very homogeneous fluid collection. And the treatment for Morel-Lavallée lesions depends on the stage at which the lesion is detected. And we can see bending, aspiration, or incision and evacuation of the lesion. And the image methods can have an important role here to guide aspiration and to guide procedures. So I have only 10 minutes. I will end my presentation here, but I'd like just to just remember some points, take-home points. Morel-Lavallée are closed degloving type injuries that results from post-traumatic hemolymphatic effusions, classically described on the type, but I also can see in other sites like knee, cuff, and lumbar regions, how was in our case. The severity of the traumatic process leading to the formation of Morel-Lavallée lesion will differentiate from acute to chronic lesions depending how the patients evaluate. So it's not only important to make the diagnosis, but also follow up these patients with image methods, so you can see if this fluid collection will be observed and the patients will have a good prognosis, or if it will chronify or even can be infected and you have some problems with that. And the evolution of the blood products, fat content, and formation of granulation tissues are important determinants for the late and chronic appearance of the Morel-Lavallée lesions. So it's very important to the radiologist to know this diagnosis, to remember the different kinds of presentations, even if you don't want to classify, but you must know the different kinds of presentations and the different phase of evolution of this kind of lesion, so you can describe in the best way you can. Okay, so thank you very much for your attention, and here are my social media contacts for any doubts. And in the end of the presentation here, at the end of the section, we'll have a Q&A, so you can ask anything. Thank you very much.
Hi, good morning, everybody, or good afternoon. I'm Hilary Humans. It's my pleasure to introduce my friend Marcos Loreto Sampaio, who is the musculoskeletal ultrasound lead at the Ottawa Hospital of the University of Ottawa in Canada, where he was the former musculoskeletal fellowship program director. He's a musculoskeletal radiologist with a special interest in both ultrasound and MRI techniques. His research has focused on imaging of spondyloarthropathy, neuromuscular disease, dynamic ultrasound, and Dixon MRI technique. He was previously voted best radiology teacher by students, residents, and fellows at the University of Ottawa. He holds a degree in electronic engineering and is an amateur musician. So I'm looking forward to the best teacher teaching us something about sports imaging. Share your screen, Marcos.
Thank you so much, Hilary. Yes. Okay, so let's see here. Please, can you just confirm if you can see my PowerPoint presentation?
Yes.
Yes.
Thank you so much. Thanks for the introduction, Hilary. Thanks, Hilary and Aline, for the invitation to participate. It's my first participation with the Rio de Janeiro Sociedade of Radiology and OCAD to present cases like this. So it's a real pleasure. Thank you so much, and let's get started. So this is the team of MSK RADs here at Ottawa. For you to have an idea, and I don't have anything to disclose. So today we're going to talk about this person here. So 38 years old. He presented at the ER with a history of recent onset of pain at the proximal kind of anterior aspect of the arm, deltopectoral region. Bodybuilder, very strong guy, and clinically it was a quiddy pec major tear. At the ER, we end up doing an ultrasound of that person. Usually here, we do have the sonographers doing the study, and we go there to help and to do whatever else we need. Now, being an ultrasound of the pectoralis major, I mean, it's one of those that doesn't really come every day, and it's normal for us to be a bit unfamiliar with the anatomy and whatever we should be looking for there. Right, so let's quickly review. Let's put everyone on the same page. Let's say in terms of how to assess it, and then we're going to see the images. Okay, so we're going to spend a couple of minutes talking about the anatomy and the appearance of pec major in ultrasound. We'll do this pretty briefly and directly. Simplifying anatomy, we see the humerus in this region, the humeral head here. We have the clavicle, the manubrium, and the sternum, and then we have the very large sternocostal head of the pectoralis major, which the origin all along this medial margin here, and the tendon there attached at the humerus laterally to the bicipital groove. And superiorly and somewhat more superficially in relation to it, you do have the clavicular head with that kind of orientation, as you see. The orientation of the fibers counts a lot when we're doing this study. It's going to help us. Now, the most inferior fibers of the sternocostal head are called the abdominal lamina of the muscle. And as you can see, the fibers, as they converge to become the tendon, you have a very short myotendinous junction here. As that happens, they have this really, tilted angle here, okay, to the attachment. While the more central fibers, they kind of go more linearly, let's say. They're not too much angulated. Okay, the same about the clavicular fibers. When we do cross-sectional imaging of that level of the tendon, let's take a look at what we see. This is going to be important for our sonographic images. So that's the humerus. This is the bicipital groove, a bit exaggerated at the level of the attachment, but it makes it easier to understand. This is the bicipital tendon there. And then we're going to have the deepest layer of that pectoralis major tendon. That is exactly that contribution of the abdominal lamina, those most inferior fibers. Okay, and then we have that manubrial lamina, still the sternocostal head, those more central fibers and more cranial fibers, providing us with a somewhat little more superficial layer of the tendon. And finally, we do have the fibers of the clavicular head, which are going to be even more superficial typically. Now, as you can see at the attachment, things change a little bit, and we tend to have what is so-called a bilaminar tendon at the attachment. So we end up having a deepest layer or posterior layer with that abdominal lamina contribution, and a more superficial one with all fibers together from the manubrial lamina and the clavicular head. The tendon is quite thin, measures around 0.5 centimeter in thickness on average. Good. So now when we are recognizing the anatomy in any modality, that's another important relation here. We can, the sternal head is very easy, right? You just position your transducer, or you're looking at your image, it's a very large muscle anteriorly in the chest. Now the clavicular head, you can get a bit stuck and you can have some confusion there. So a good landmark is the cephalic vein. The cephalic vein actually separates the deltoid more laterally from the clavicular head more medially. And it's a very good landmark, as you're going to see in a second. That tendon has variable thick extension, length, from 1 to 5 centimeter in most people. Good. All right, so that's a nutshell of anatomy. So how do we do that in ultrasound, and how does it look like? If we position our transducer like that, at the very attachment of the tendon, that's what you should be seeing. The humerus, the tendon of the long head here, and the tendon, as we discussed, directly medially. If you keep moving your transducer more medially, you are going to be able to follow the myotendonous junction here. That's the sternal myotendonous junction. You can see that clavicular head a little more superficial. That's the myotendonous junction of the sternal head. And if you keep going medially, you're basically following the muscle fibers. For the clavicular head, let's start with that transverse image. So we have the cephalic vein here, then laterally to it the deltoid, and medially to it the clavicular head. Now, when I flip my transducer and it's now longitudinal to the clavicular head fibers, I can see its origin at the clavicle. I can see the fibrillar pattern there. I can follow it distally, right, towards the myotendonous junction. It gets very difficult at this area here, okay, close to the attachment. But that's what it should be looking like. And in depth, you're going to be seeing somewhat perpendicular image of the other head, of the sternal head, deeper to the clavicular head. Very good. Okay, so let's see our case now. Patient pointed out the area of tenderness, and he said, I think it's here. And that was more or less still the region of the muscle, kind of close to the myotendonous junction. The sonographer started there. Okay, my suggestion to you, if you're doing a case like this, actually do the contralateral side first and kind of prime your eyes and your whole feeling for the anatomy, and then you go to the abnormal side. But he started like that. So, but anyways, what we see, there's some kind of distortion of the anatomy here, some kind of loss of a nice shape of muscles and that fibrillar pattern. We see some long axis of the clavicular head and maybe what looks like sternal head here, but I don't see fluid. Then the next image we were provided is a long axis of the clavicular head, right? So fibrillar pattern here, that's normal, and deeper to it, there's something funky happening here. And as we saw in that anatomical image, that should be the sternal head contribution. There is something happening there. A little more of the same clavicular head here, but now the transducer was rotated, and now we are seeing what should be the long axis of the myotendonous junction of the sternal head. So the person is trying to figure out what's the myotendonous junction, what's the tendon here. Whatever is there is really heterogeneous. finally the tendon appeared. Yeah, but it's still heterogeneous. There's some kind of hyperechogenic lines there, and what's happening, right? But anyways, there seems to be something in continuity from that myotendon junction to the attachment. Looks like the tendon, fluid could not really be seen around it. And with some good will, we might even maybe be able to separate some kind of layer, some kind of contribution of the clavicular head tendon and the rest of the tendon with the sternal head. But anyways, there was something really heterogeneous there. And at that point, the sonographer was really lost. Okay. And the radiologist was called to take a look at the case. When we follow to the insertion, again, we see this, what looks like a hyperechoic line going together with the tendon. But anyways, at this point, we think the tendon is in continuity at least, and there is not a collection, which is a good thing. To make things a little worse, when the transducer is rotated along the long axis of the humerus at the very attachment of the tendon, that was seen. Some kind of, there's a well-defined structure here with intense acoustic shadow, and close to it, there are again those hyperechoic lines. So let's see that. This is a long axis of the tendon. I mean, a short axis of the tendon. I'm going to run it again. And let's look. So we're coming from the myotendon's junction. There are those hyperechoic lines, and we're going towards the attachment itself. And we get to the attachment here. So myotendon's junction here, at the center of the screen, then some hyperechoic lines. Then we get really close to the bone. There is that thing there with a shadow. Then looks like we got to the attachment. We keep seeing the humerus now. And at the other side of the humerus, look at that. There's something coming out from the other side. Right? So some of you already know what's that, and some of you might be pretty lost, maybe, and say, what is happening, right? What's that? Now, that's a short axis of the humerus, so long axis of the tendon. We see from the top to the bottom, we are going to be able to follow the tendon substance and the attachment. Let's see again, some hyperechoic foci. This is the tendon itself going there, right? And the humerus. And if we go back here, you see those hyperechoic lines directed along the tendon substance toward the bone, right? Towards the humerus. Interesting. So what do you think is happening there? Well, at this point, the patient turns out to the sonographer and says, oh, yeah, actually, I had a surgery there 2 years ago. So then the sonographer says, oh, okay, thank you, sir. But, come on, sir, why didn't you tell you that first? Very funny, right, Indiana? Yeah, why didn't you tell that first? But, so the patient says, well, I just forgot. And then when he looks at the patient, he says, yeah, actually, no worries, my friend. Yeah, that happens every day. Nothing to be worried about. But anyway, so we're of course not angry, but we figured out what was happening there. So we're talking about sutures and reinsertion of the pectoralis major tendon, and we're seeing a plate, a mini plate at the edge of the attachment, and then we have tunnels in the bone, and we have the suture at the other side explaining all those findings. But the tendon, at the end of the day, was in continuity. There was distortion of the anatomy, which is kind of expected in a case like this, but there was nothing really major, nothing surgical. So our conclusion for the ER physician and orthopod was that, yeah, there's no re-op involved here. He might have some kind of minor strain of something there, and the patient was then dismissed. Good. So just as a complement in 30 seconds, an MRI imaging of a similar case, post-op case, pectoralis major here, susceptibility artifacts, telling you that there was a surgery with a repair, and a bit of hard time to find the tendon in this case. But there was maybe some residual findings here, but not really an evident retraction of the tendon. This same patient that I just showed you the MRI, that was the original injury. You see the complete full thickness tear of both the clavicular head and also the sternal head. And very good. And at times, when you're talking about chronic tears, which is kind of what we're doing here today, and post-op changes, you might be seeing fat infiltration, even if it's, it's still kind of, there's some functionality. Even in partial tears, you might see some areas of fat infiltration. And that can be seen, of course, in the ultrasound too, like in this example, just see some distortion of the anatomy and loss of volume and usually hyperechoic errors at that region. Good, so I hope you found that interesting, and that's it. Let me find my video again. Thank you.
Thank you, Marcos. Now it's my pleasure to introduce Dr. Lucas Lobo. He earned his medical degree at Federal University of Bahia and completed his radiology diagnostic residence at Hospital do Serviço Público Estadual de São Paulo. He then received advanced training in musculoskeletal radiology through a clinical fellowship at the University of Toronto, Mount Sinai Hospital. He currently serves as medical director at Lab Checkup Laboratório e Imagem and works as a musculoskeletal and interventional step radiology at Hospital Aliança, Redidor, Salvador, Bahia. He's also a member of the Society of Skeletal Radiology. Please, Lucas.
Thank you, Aline, thank you for the introduction, and thank you, Hillary, for the invitation. I'm just going to share my screen here. Can you see it?
Yes, but it's not on presenter mode.
Okay,
Yeah,
so my case is a 16-year-old male. He's an active handball player, and the indication for the MRI was a loss of posterior elbow extension with posterior medial elbow pain. So the clinician wants to rule out loose body and joint pathology. So the pain is worse with full extension and during the acceleration phase of the throwing cycle. And on physical examination, there is focal tenderness to palpation over posterior medial elbow. So these are coronal T2 weighted sequences. As you can see here, there is some signal change in relation to the proximal fibers of the UCL. There is also bone marrow edema at the medial epicondyle and at the olecranon apophysis. And as you can see here, the lateral structures are normal. On the axial T2 weighted, there is, you can appreciate the edema. And also the ulnar nerve, it's quite bright. It's almost approaching the signal of the vessels. And on the T1 weighted sequences, you can better appreciate how the irregular and widen is the olecranon apophysis. So this is a good old case of a pitcher's elbow with valgus extension overload syndrome, UCL partial tearing, and ulnar neuritis. So the VEOS is a pathophysiological model for common elbow injuries in overhead athletes. So these patients, they get very high valgus stress at the elbow, especially during late cocking and early acceleration phase of the throwing cycle, which leads to extreme medial tension forces, extreme lateral compression forces, and they also get shear type forces at the posterior medial aspect of the joint. So the pitcher's elbow is a constellation of findings. The medial tensile forces are responsible for specific bone and soft tissue injuries. The lateral compressive forces are responsible for OCD injuries at the radiocapitellar joint, and the shear stress injuries cause posterior medial impingement and olecranon stress fractures. So the UCL is made up of 3 bands. As we know, the anterior band is the most important, and it experiences tensile forces during the late cocking and acceleration phases of the throwing cycle, which leads to attenuation and progressive laxity. So this example shows an acute case of a high-grade partial tearing of the proximal fibers of the MCL. There is another case showing complete detachment with extension to the FCU origin. The anterior band of the UCL originates from the inferior aspect of the epicondyle and inserts in the sublime tubercle. And there is a pitfall that we have to know. Its distal insertion may vary from the joint line to up to 3 millimeters from the articulation. There is a specific partial thickness there of the distal anterior band near the sublime tubercle, which has been described as having a T-shaped appearance, the so-called T sign. And then we go to the lateral side. This lateral compressive forces at the radiocapitellar joint can lead to OCD lesions, usually in the dominant hands. It's an overuse injury. And why does this happen often in the capitellum? People think that's probably related to the tenuous blood supply. So these chronic compressive forces, they lead to ischemia and necrosis. So as you can see here, there's a large osteochondral defect at the anterior aspect of the capitellum. And then we go to the third phase, which is the extension overload. So they're pitching, and when they are in full extension, the olecranon keeps jamming on the back of the fossa, and this can cause symptoms of impingement. It's an overuse injury and results in injuries with chondrosis and osteophytes and olecranon fractures. So there is an example here, it's an MR arthrogram. So there is a thickening and remodeling of the UCL. And on the axial images, you can see that there is some chondrosis at the posterior medial aspect of the joint with contrast interposition. And I just want to share this article very quick. It was an interesting one that came out recently on AGR, in which they assessed this new position, which they call fever, on unilateral joint space measurements and evaluation of UCL injuries in pictures. In general terms, they concluded that the fever view improves diagnostic confidence, potentially improving MRI evaluation of throwing athletes. And that's how they position the patient, lying on his side with the elbow flexed. They put some sandbags to induce a valgus stress. And as you can see here, the images were acquired through the UCL. And that's the beautiful image that they got. The UCL is stretched. You can see thickened. There is some signal change and also some widening of the space. And I think that's the last one. That's fever, no fever. As you can see, the UCL is thick. There's some signal change. There is widening of the space. I think was the last image. That's all I got. I thank you very much for your attention.
Is Diego back?
Yes, I am. I'm done. Thank you.
Okay, good. Welcome back, Diego. It's my pleasure to introduce Dr. Diego Lemos, who did his medical training at the Sociedade Libre de Cali in Colombia, his country of origin. After that, he moved to the United States and started his radiology residency training at the Louisiana State University of New Orleans in Louisiana. But thanks to Hurricane Katrina, which was really a big hurricane, he was relocated to the University of Vermont, which is a very different place in the United States, a little bit colder than New Orleans. He completed his musculoskeletal radiology fellowship at University of California, San Diego, and then returned to University of Vermont, where he's been the musculoskeletal division chief since 2009. Dr. Lemos has published more than 20 articles and 4 book chapters and has presented many, many posters and electronic exhibits around the United States and around the world. He's an active academic musculoskeletal radiologist on social media. He's a Twitterer and an Instagrammer, and his handle is at DFLemosMD. Okay, Diego, share your screen.
All right. Let's see if, can you guys hear me well?
Yes.
Okay. So thank you, Hillary and Elaine, for the invitation again. It's a pleasure to participate again in on this series. And today I'm going to present an interesting case that we had a few months ago. It's a 40-year-old male who was actually water skiing here in Lake Champlain when he had a sudden water skiing traction injury. So the boat pulled too fast and he got a traction injury on his shoulder. He wasn't able to continue water skiing due to pain in the posteromedial aspect of the shoulder and back. And the pain actually continued over the next 3 weeks or so, So he consulted with those symptoms. Initial X-rays were obtained, and that was followed by a CT and a subsequent MRI. These were the initial radiographs, an AP neutral, a Grassi, and a transscapular views of the right shoulder. And at first glance, nothing really jumps up, but let me just show you this countdown magnified view where I think that we can appreciate an irregularity in the medial cortex of the proximal humeral diaphysis that was concerning. At the time, a CT was obtained, and this is a coronal reformation that shows again the cortical irregularities. And I think I have, and this is an axial at the same level showing the same findings. So an MRI was subsequently obtained. And here we have T1 non-fat SAT, T2 fat SAT, and T1 fat SAT after intravenous contrast administration. So let me show you the abnormality. You can see here focal area of alter intramedullary signal. The epicenter is actually that area of cortical irregularity. It's like isointense to skeletal muscle on T1 weighted images, hyperintense on fluid sensitive sequences, and shows evidence of significant enhancement both in the bone as well as in the adjacent soft tissues after intravenous contrast administration. And here you can see the area of the cortical irregularity and some of the peristitial fragments there adjacent to it. And as we continue going, you can see that and here we have a sagittal oblique fluid sensitive sequence at the same level. And you can see the same findings with the focal bone marrow edema at the time, very concerning for actually a tumor. But the clinical history didn't fit, nor the imaging findings, particularly on the MRI, where you can see that there is focal hematoma, and then you have these tendons inserting on that footprint in the medial cortex, posterior medial cortex, if you will, of the proximal humeral diaphysis. And here you have actually some of the more cranial vertical fibers of the Latissimus dorsi tendon and part of the teres minor tendon that were pulled from the footprint in the humerus. So let me show you the axial images. Here you have just distal to the level of the lower tendinous insertion of the subscap, almost at the muscular insertion level. You have the LHB, the long head biceps tendon. And as we get towards the area of abnormality, you can see here the pec coming there, and this is part of the Latissimus dorsi. And some of the fibers of the Latissimus dorsi are pulled. The footprint of the Latissimus dorsi is almost like 3.5 to 4 centimeters. So somewhat similar. I think this case actually correlates, complements well the beautiful pec case that was shown early. But this one is not the pec, is the Latissimus dorsi, and mainly the teres major. Both of these tendons sometimes can have a common footprint, but there actually can be separate footprints. I'll show you some cadaveric pictures in a couple of minutes. So you can see the focal hematoma and the cortical discontinuity and the avulsed fracture fragments. This was now like almost 4 weeks after the initial injury, so there's still some edema and myofascial edema and fluid tracking along the planes. So the diagnosis was indeed an avulsion of the teres major Latissimus dorsi tendinous insertion at its distal footprint in the humerus. And I thought that the case was interesting because the workup after the initial radiographs and the CT was concerning for a neoplastic lesion. But again, the clinical history didn't fit too well. So we found this article on the Yellow Journal on AJR of the American Regenerate Society from 2005. It's a multi-institutional article work presented by Dr. Anderson, Suzanne Anderson, and Line Steinbach from UCSF, where they presented 5 patients with tears of the Latissimus dorsi that looked like a tumor. So they coined the term pseudotumor of the upper extremity in these particular patients. And those 5 patients, here they are. The first one was just not really history of trauma, just several years of shoulder pain. Second patient was minor trauma. but the last 3 patients were all athletes and sports injuries: a basketball slam dunking injury, a volleyball player that was spiking a ball and developed the pain, and then an Olympic vaulting gymnast with chronic pain. So this is an injury that can certainly occur in the setting of sports. Of a sports injury. This is one of the cases, one of the 5 cases presented on the AJR article, and it shares several similarities with our case. You can see the cortical irregularity along the medial aspect of the proximal humeral diaphysis. There was a bone scan that showed the focal area of increased radiotracer uptake, and you can see that the MRI is very similar to our case. This is another article, this one on the American Journal of Sports Medicine from 1998, from Dr. Spinner and colleagues, about an avulsion injury of the conjoint tendons of the latissimus dorsi and the teres major muscles at the humeral footprint. And you can see that the X-ray shows again a cortical irregularity in the proximal humeral diaphysis, and you can see the MRI showing the avulsive findings, the soft tissue edema and fluid tracking along the path of the torn tendons. So not all injuries happen actually at the footprint, at the humeral insertion. That's the most common occurrence, but not infrequently or occasionally you can see rather injuries along the myotendinous junction. Altogether, these injuries of the latissimus dorsi, either in isolation, the LD, or just the teres major, or both, are not that common. They are relatively uncommon, but you can see them in some particular sports. So this is an article that some of our colleagues from Spain, with Dr. Pedret and Ramon Valles and Fernando, they published this article about 4 elite athletes that they found injuries of the latissimus dorsi, but those injuries in this case, in these 4 cases, were not actually at the distal humeral insertion, but along the distal myotendinous junction. So the 4 patients, one was actually a tennis player, one was a bike trial athlete, and the other 2 were pelota vasca players, which is a specific type of sports that they play in the País Vasco, where they throw a specific ball, and they play that. So the 2 pelota vasca players actually suffered re-injuries. And I'm going to show just the images of one of those cases. But one thing that I want to emphasize is this particular anatomy of the latissimus dorsi and its relationship with the teres major. They can have this common tendinous insertion, or they can have separate but adjacent footprints. But what is interesting is that the latissimus dorsi kind of rotates on itself just before its insertion in the bicipital groove, in the intertubercular groove of the humerus. Okay, and here are the footprints in the lateral and medial portions of the intertubercular groove for the latissimus, for the pectoralis major, for the latissimus dorsi, and for the teres major. So the mnemonic that sometimes we can use to remember those is plate for pectoralis 1, latissimus 2, and teres major 3. So remember that. And this is one of the cases that our colleagues from Spain published on SRad Radiology article from 2011. And as you can see, the injury, this was one of the pelota vasca players. Actually, this was the initial MRI at the time of the first injury, with the injury center along the latissimus dorsi myotendinous junction. And this was a re-injury that happened like 4 weeks after the initial episode. And this one was more distal, and the edema was extending all the way to the distal tendinous insertion into the humerus, which was attenuated. So just remember that not all injuries occur at the distal insertion. Not all of them are just soft tissue avulsions, like they can pull a little piece of bone, like in the case that I showed you and some of the examples that we already shared. And sometimes the injuries can be along the myotendinous junction. So a couple of nice diagrams from Ratzers about this particular anatomy. You can see the latissimus dorsi, and you can see how it turns on itself and its relationship with the teres major. This is a posterior view, and this is seen from the front and anterior projection, where they cut the long head biceps tendon and the short head biceps tendon and the coracobrachialis, and the pec was reflected. So you can see very nicely the relationship of the latissimus dorsi, which is more anterior and extends more cranial than the footprint of the teres major. These are two beautiful cadaveric dissections done by Dr. Chala, by Jorge Chala, that was published actually on an article in the Journal of Arthroscopy from 2018. And it can show you here initially the latissimus dorsi footprint. Here's where the pec inserts, and here is the teres major. So he actually reflected here the latissimus dorsi to the side, and you can see that there are two separate footprints for these two tendons. They're adjacent to one to the other. They're like 4 millimeters at the most of separation between the footprints, and sometimes they're just together, but that's the anatomic relationship. And on MR imaging, we can see injuries of both tendons, or just an isolated latissimus dorsi or an isolated teres major. Dr. Holly Spotter and colleagues from the HSS, from the Hospital of Special Surgery in New York, published this article in the Orthopedic Journal of Sports Medicine about the MR imaging grading system of teres of the latissimus dorsi and teres major. So I'm just going to share with you the classification system. I don't use it like this, but it's important in terms of how you can describe this type of injury. So whether it's a grade 1, which is just a strain with a little bit of fluid tracking along the fibers of the teres major and the latissimus dorsi, or a type 2, which is a partial tear at the footprint, versus a grade 3 and 4 that are complete tears. And the designation of A or B means what it means is if the tear occurs at the footprint or along the myotendinous junction. And once that you decide that, if the retraction is less than 2 centimeters of the torn fibers, then it's a grade 3. If it's more than 2 centimeters, it's a grade 4. And this paper was about just professional pitchers. And they found that the patient with more than 2 centimeters of retraction of the torn fibers did very well with surgery, but actually the other professional pitchers that didn't have grade 4s, but grade 1, 2, or 3, didn't require surgery and returned to play with same level as before. So there's no definite treatment for these injuries. Some people do operate, some others do not, but patients relatively do well in these cases, and they can return to play. This is another article about, I just wanted to share it because it's a myotendinous junction injury, and these ones are less common than the distal insertion tears that I just showed you. This is a case series about baseball players from 3 Major League Baseball clubs over a total of 10 seasons, and they had access to all that data, and they were able to pull up like 10 patients that had those injuries, and all of them returned to play, whether they had operative or non-operative treatment. Here you have more articles about injuries of these two structures, the latissimus dorsi and the teres major. Tennis player, baseball pitchers, rock climbers, boxers, crickets here for our friends from Australia. They can also have this kind of injury. They presented this nice paper with 4 patients. You can have isolated injuries of the teres major, and here you have several examples on baseball players, as well as 2 of them with water skiing injuries, such as our patient that injured here in the lake. And since this is in conjunction with Brazil, I need to mention that you can also have injuries to these structures in soccer, in football. And this is a case that it was reported, a case from Sao Paulo, about a goalkeeper that had that injury, and this is the specific movement that he was doing when he threw the ball and felt the pain. And here are the pictures with the asymmetry in the soft tissues and the tremendous hematoma and swelling about the at the distal insertion and proximal retraction of the torn fibers of the teres major mainly. So in summary, I show you a case of a pseudotumoral appearance of a bony avulsion of the latissimus dorsi and teres major. Remember that they can look a little bit aggressive. on it, but if you have the clinical history and with all the imaging findings put together and the different imaging modalities, you can come up with this diagnosis. Remember that it's important to mention if it's both tendons or one of them, if it's at the footprint or proximal to it at the myotendinous junction or not, and if the degree of retraction, if it's less than 2 centimeters or more than 2 centimeters. Not everything is a pseudotumor. We had this unfortunate case of a real tumoral lesion on a patient in the same location. Unfortunately, a MET on a non-small cell lung cancer that occur in the same area. So yes, it's a pseudotumor, but you can have real tumors in that area. This is the X-ray. So I thank you all for your attention, and thanks again for the invitation.
Diego, don't go away.
Okay, I'll stay.
That was wonderful. I'm a little, now I'm a little depressed that you ended on such an unfortunate case. But my question is, in my experience, even with pretty large avulsions, I see relatively minimal marrow edema. How do you explain the degree of marrow edema and enhancement? Is it somehow related to the fact that he waited 3 days to present? I mean, those cases that were published as pseudotumors, they were not, they didn't look like pseudotumors, frankly. Yours looks,
a real
like a tumor.
Yeah, I think there is a combination of both. I think that the time that some time elapsed between the time of the initial injury and the time of imaging can explain that. Now, it was a significant injury, and if you keep in mind the size of the footprint there, I didn't have time to show everything, but there are very elegant articles in the literature about the geography of the footprints of these two tendons, and they can be quite long over that segment. So conceivably, if you have a tear that involves the entire footprint, and particularly you have this avulsive bone marrow edema, this avulsion, bone avulsion with cortical irregularities, you can have that much bone marrow edema. And as you know, the bone marrow edema can enhance like this. It was concerning. I'm going to tell you the truth. I mean, we were worried, particularly with the MRI, with the CT, and with the plain films. The MRI and the clinical history help us, and the fact that
it's hematomas enhancing, right? I mean, that's enormous.
Yeah, and one thing that I didn't have time to show, but also to include in the differential, is hydroxyapatite crystal deposition.
Exactly.
I have had cases, actually I have a beautiful case that I just didn't have time to include it, with at the insertion of the pec major, and the comet tail sign causing the erosion of the cortex, and then hydroxyapatite deposition at the footprint of the Latissimus dorsi and at the footprint of the teres major. So, and as you know, there are a few articles in the imaging literature that show not only the cortical irregularity, but focal areas of significant bone marrow edema adjacent to the focus of head, even in the absence of cortical erosion. So I think that, the bone marrow edema enhancement can be misleading, but I think that biomechanically, the time of injury between the imaging and the trauma and the size of the footprint can explain why it was so focal. And the fact that the follow-up MRI show resolution of
well, that helps. Yeah, sure.
Yeah, that helps a lot. The patient is still alive. So
very good.
Yeah.
Okay. Eleni, do you want to ask your question?
Yeah, for Marcus. When pec major lesion is not suspected, he answered already.
It's okay. If you want, I just typed it. Sorry. I can, if you want, I can say too, whatever you guys prefer.
Yeah, please explain.
So wait, finish the question.
Okay. So when pec major lesion is not suspected clinically, and you're running a routine shoulder protocol, and then you suspect that there is a pec major lesion, but the shoulder MRI don't go far enough distally, what would be a good sequence of playing to make the diagnosis without running a whole pectoralis protocol? Or would you run a whole protocol?
Protocol, yeah, I understand, yeah. So if you're lucky enough to see that there was something around there and you're just, close by, and there is time to do something, first question is how much time do you have to do whatever you need to do? So let's suppose you have just less than 10 minutes. Okay, so you need to run some kind of rescue sequence, even if to be able to report that there is something there, it's more or less this, and you know what, he needs a new study dedicated and whatever. But the two things I would suggest would be your shoulder coil is placed there, but there is some bad signal, but there is some signal that you can use to go a little more distal in the shaft of the humerus. So I would just do an axial, probably T1 and maybe an axial stir, but the idea is to better characterize the pectoralis tendon itself, and maybe a little bit of the myotendinous junction. So you could use the field of view of the shoulder that you have the axial, just keep going down, and you're going to see the tendon attachment quite well, right? And actually, if you start pay attention to all shoulder MRIs, we almost see it in many of them. Now, if you want to get a little more signal, especially because your coil is already kind of the end of it, you can increase the field of view, and then with that you actually include a little bit of the myotendinous junction. So you can go like, I don't know, like 19 or maybe even 20 field of view. You're going to lose a bit of resolution, but now you get more signals, noise. It's a little better the image. So I would do an axial T1, I think, and I would do a fluid sensitive sequence, which because I know the fat suppression is going to be bad, I would go for a stir. Now, that is going to take probably more 5 minutes for you to do. The last thing I would do would be a coronal stir. You can use the gantry coil if you want, and use a field of view of like 22, 25 to include the pectoralis to the humerus. And don't expect big resolution at all. The idea is just to see if there is a collection, where there is edema, something like that. So at least you can stage more or less the thing.
Great, thank you.
My pleasure.
I had a question for Lucas. I thought I read that the T sign has been determined to be unreliable and can be a normal appearance. What's your experience and opinion on this matter?
It's a very good question, which I don't have a good answer. The problem with those lesions that they are usually treated non-operatively. They never go to the OR, so you never know if there was a lesion or not. So what I usually do is, if the patient is symptomatic and the contrast is extending too far, I would say 5 millimeters, more than 5, something like this, I call it. But I don't have a good answer. I'd like to hear your opinion and the others.
Anybody else in this crew have an idea? Okay, we're stumped. Thanks.
Okay.
And I have a question for Francisco. When you see a patient with Morel-Lavallée, will you attempt aspiration first, regardless of when the injury happened, how chronic it is, and the imaging appearance? And if so, do you inject any sort of sclerosing agent? I know that the issue with Morel-Lavallée lesions, which is what makes them special, is that they can reaccumulate and require surgery. After aspiration, do you find that it helps to bind the limb or use a compression dressing? I've only done a few of these, so I wonder what your experience is.
Okay, it's an excellent question here, because we can discuss some treatment options and how we use in our protocol here. So the first question is this a professional player, for example, or it's just a regular patient that is not a professional? So that's the first question, because if he's a professional player, it's an entirely different protocol. So you want to try to recover the patient and make him back to the game as soon as possible. So we try to shorten the time to recover as long as we can. So if it's a professional player, we usually try to aspirate this and to put a compression band in an earlier phase, in acute phase. But it's not in all the cases, for example, in all kind of patients. If it's a regular patient, we wait until for 2 weeks, and if, because sometimes the body will absorb spontaneously this collection, and so if we notice in the follow-up exams that in these 2 first weeks the volume of the collection is reducing in a significant way, for example, more than 20 or 25 or 30% in each week. So we can wait for the spontaneous absorption of this fluid collection. After 2 weeks, if you don't observe any improvement, so you can try to aspirate. And the sclerosing agents, in some places, they use kind of antibiotics and other sclerotic agents, but here in our service, we don't use it, okay? I don't have experience using this. We just aspirate and we put the compressing dressing.
Thank you. But my question, the first part of the question was, will you try to aspirate even if it's more chronic? Or if the appearance shows that it's encapsulated, is it worth a try regardless of the appearance?
Okay, if it's more than 2 weeks, it's not, the image shows chronicity, and it has if it still have fluid inside it, it's interesting to try to aspirate. But sometimes when it got chronic, it's not so a well-defined fluid collection. It's infiltrated, and we don't have a main place to aspirate. So it's not so easy. Depends on the case. When it's chronic organizing hematoma, sometimes you don't have anything else to aspirate. But if you have a fluid collection well-defined, I think it's very helpful.
Thank you.
Okay, I don't see any more questions here in the chat box. We'll do a short break in December, and we will get back in January. So thank you all for joining us today, and with that, I will end the session. Thank you.